Well, good evening, everyone. Hi, and welcome to the second annual spring meeting for the cardiovascular team members of the Nebraska ACC. I wanted to welcome everyone here today. We're very excited. This second event is a lot bigger than our first event, but we'll keep it growing, and we're happy that you guys were able to join us today. So just a few things before I turn it over to Jessica. On behalf of all of our Nebraska ACC leadership, I wanted to welcome you guys and hope that you have a good evening and are able to learn just a few things from both of our speakers. Tonight's event does have continuing education for nursing, one contact hour. So if you go to our event website, the link is already live, and so you just go through the survey and you'll be able to get your certificate. And of course, also want to thank our industry exhibitors. They're our partners in all of these events, and I hope that you had a chance to talk to them in their booths. We would not be able to meet all of our Nebraska ACC goals without their support. So with that, I want to welcome Jessica to the podium.
All right, thank you all so much. This is very heartwarming to see you all sitting here. As Carmen alluded to, doubling our attendance, at least more than doubling from last year. This is fantastic. So thank you very much. Yes, thank you. Thank you for being here. This is so lovely. We've got representation from a lot more, not only Nebraska medicine, but we've got Bellevue here. We've got lots of, and if you're from a organization other than Nebraska medicine or Bellevue and the industry, raise your hands. Trish, yes, from BA. Thank you, Trish. It's nice to see you, Trish. I haven't gotten to give you a hug yet. And everybody, just thank you so much for being here. We really appreciate it. In our industry, again, we could not do this without you, and so we're so grateful to you and your support. So I put some numbers up here. So again, we've more than doubled, and again, more than doubled our industry partners as well. So thank you. Also deserving a lot of thanks is Carmen and Tanya. So Carmen is our executive director of the NCC or Nebraska ACC chapter, and Tanya is our operations associate. And together they put on fantastic meetings. They also are responsible for the annual meeting for the big Nebraska chapter meeting in the fall. So you guys do a lot of work, and so thank you so much for all of you that you do. So a round of applause for them. And also, I wanted to officially welcome Dr. Anuradha Tunangula. She is our incoming Nebraska ACC governor starting in 2023. Do I have that right? Okay. So currently, she is our editor-in-chief of our Nebraska ACC newsletter that we have. She is a cardiologist at the CHI Health Nebraska Heart Hospital in Nebraska Heart in Lincoln, with multiple certifications, including interventional cardiology, echocardiography, and nuclear cardiography. And so we are so thrilled to have you on board. I was just so excited when you were elected, and I can't wait to celebrate with you while you jump on board. And I know it seems really early that you're coming on board, but there's so much for you to learn, and so please don't hesitate to reach out. Yes, yes, of course. So just to reiterate a couple goals of this annual event, and this is specific to the CBT team. So again, this is all of the non-physicians. So it's kind of like the cool club of all the non-physicians, is to provide all of you and provide and learn about professional development opportunities. So you can be a speaker at this event, which sometimes I gotta really pull teeth to have happen, but once you get it done, it's a very it's an honor to do it. You can also, as a member of the ACC, be a speaker at an ACC national event, which is also a big deal. I put up Paul Doga, she's one of our PharmDs at Nebraska Medicine. He had the opportunity, he does a lot of national speaking, but he was one of the panelists at a breakout session at the scientific sessions this year. And he did an amazing job, and it was a really cool thing to watch. There's also poster presentation opportunities, and then also the article for the CBT section in our newsletter that we have. And hopefully a lot of you have already seen that. I probably reached out to many of you to be an author. So that will continue to happen, because that is a quarterly newsletter, and I love having a plethora of different backgrounds of all of the different authors that we have. So if I reach out to you, don't be surprised. Obviously, there's a lot of networking and collaborating opportunities here at this meeting. And then obviously also we want to grow our ACC membership. So I know a lot of you, not all of you are ACC members, but we want to increase our ACC membership because there are so many things that the ACC offers. First and foremost, there are so many CE opportunities, and all of us need CEs to maintain our licenses and our certifications that we have, and so they're innumerable. So that alone is worth it, and so those are due at the end of every year. Real quick about our newsletter, I've listed all of the authors that we've had in the past. A couple of examples over here on the right of our past authors that we've had. In the future, I would love to have somebody from cardiac rehab. I would love to have a sonographer or a dietitian or another rad tech. So if you or someone you know is interested in being an author, it's a great resume builder, so please let me know. It's a short and sweet 250 word article, so nothing too scary. Right, Marty? All right. Moving along, here's the schedule of our events. So we have completed the first cocktail reception and exhibits. We're going to have Lee speak first on order set optimization and how it leads to efficiency and safety. We're going to have a lovely dinner starting around 7. We're going to be pushed back a little bit because we're getting a late start. I'm sorry, I'm talking way more than I planned to. And then Marty will have a wonderful presentation on pharmacy presence in a cath lab, and then we'll close out around 8:15. So I want to introduce Lee. So Lee is a dear friend of mine and has been a nurse for 16 years, and he's got a plethora of experience in many specialties, most recently in the ICU setting and also with Epic, at least for the last 6 years. I've had the pleasure of working with Lee for the past 3 years. He's a fantastic person, and he's been immeasurably helpful in making my patient and staff safety goals and efficiencies a reality. So please help me welcome Lee up to the podium.
Hello, and thank you for having me. Thank you, Jessica, for encouraging me to be here and give this presentation. So my name is Lee Hansen. I work at Nebraska Medicine. I am a senior analyst. I'll get to explaining kind of exactly what that is here in a moment. But I'm here to talk to you about order set optimization and how it can lead to efficiency and safety for our patients. Quick disclosure, I'm not here, don't have any financial obligation, and not here to sell anything. So a little bit about me, senior analyst, what do I do? Well, what I do is I'm on the other side of the computer system. When you need something updated within the computer system, I'm one of many, I shouldn't say I'm the only one, I'm one of many to reach out to make those happen. I've been in Nebraska Medicine for 5 years now. I first started working there, and I did provider training. So I taught how to use Epic, standing in front of 110 some odd residents, and they all think they know how to use Epic. So teaching them how to use it could have been was a little tricky at times. I did that for about 9 months, and I transitioned into the role I'm in now. So I just really want to get my hands into the actual build and be on the opposite side of the computer and really trying to help with efficiencies on that side. A little bit more of my background. I've been a nurse for 16 years, half working in med-surg units, half working in the intensive care, and about 6 years of that I did travel nursing. So worked in multiple different charting systems. I liked all of them. Would say I have a little bit of a bias towards what I'm using now, but yeah, every system is great, and I do feel like the computer system, I feel like in general has optimized efficiency and workflows for patient safety. So having worked in technology, I feel like everybody may or may not have had these feelings at one point or another with a computer system. Oh, sorry. Oh, hoping that works. There we go. It's a little icebreaker for you here. So I'm sure we've all had that feeling at one point or another. So I'm here to kind of help guide us through our charting system and how we can not feel like that. So I brought 3 objectives to you. One thing about, hello? So, technology. All right. First step on a computer is turn it off and turn it back on. All right. So 3 objectives that I'm bringing here to you today regarding order sets. Number 1, identifying a process or owners for communicating any problems or enhancements within the electronic medical record system and or the order sets that you're working with. Number 2, ensure order sets align with our current policies and protocols. And lastly, establishing a protocol or a process for regular reviews of your order sets related to our policy and or any practice changes that may happen. New procedures come out, new ways of doing things. To get to these objectives, I'm going to bring up a case scenario, and I'm sure almost everybody in this room should be familiar with SBAR. Me having the nursing background, that's kind of what I work with almost every day when I was working on the floor. I'm going to bring to you a patient case, very fictional, nothing real here, but something that could happen on the floor in a hospital. And what I'm really trying to present is not necessarily the patient case, but the order set enhancements that could have happened with this patient case. All right, so situation/background. So we have a middle-aged man being admitted to the cardiac floor post-operatively after having a heart cath and had an intervention done for a stent. The access site was a right groin. He came back to the floor with a sheath in place. Doesn't happen very often, but it does happen. Noted that the post-cath order set was utilized, so that's a good thing. The orders in there, most of the orders inside that order set had been from 2013, and I'm bringing this case to you 2018. So had been 5 years since that order set had been looked at. The nurse pulls the line, the sheath without complication, and puts pressure dressing in place. So no problem so far. Immediately after that, the nurse leaves the room and the patient tries to get out of bed, trying to go to the bathroom. Patient immediately notices some swelling at his groin site and notices blood oozing out from underneath that pressure dressing. Again, completely fictional case, but something that definitely could happen on the floor. Assessment, so critical elements and some of the contributing factors here. So the patient's bleeding at the groin site, obviously because bed rest was not maintained after that sheet pull. It was noted within the order set that there were no specific orders regarding access site maintenance. So whether specific site, so was it a groin site, was it a radial site, brachial, and what to do with that. Did they come back with a sheath or without a sheath, and what directions to do with that? As well as, do they need bed rest? Do they not need bed rest? And how long do they need bed rest for? Nothing in the order set explained any of that. Also, activated coagulation time, or ACT, wasn't checked prior to the sheath being pulled. But in the order set, there was no orders marked to check that ACT for pre-sheath. Even though, I mean, probably standard policy, most nurses learn that, yeah, you probably should be checking an ACT prior to a sheath pull. There was no orders calling that out. Also, lastly, was education was not there. There was no education with that order set noting post-cath activities, so bed rest orders, your wound site care, head of bed, things like that. This was all noted to not be in this order set. So, recommendations. Obviously for the patient's pretty straightforward. Let's get that patient back in bed, get him lying in the supine position, get your pressure held for 20 minutes or whatever your hospital's protocol length of time is, and obviously notify your provider if it's not already done. What we're really trying to get here to though is your order set. So main thing for recommendations is updating your order sets. So checking them to ensure that we're following current protocols that for patient safety, protocol adherence, and workflow efficiency. So now we get to those objectives. First one, identifying a process, again, for communicating problems or enhancements within the electronic medical record system and or order sets. So current process right now is you enter a ticket in or a service request, you get a hold of an analyst of some sort to make the changes within the order set, because they're the ones that have the backside access that can update these orders or order sets and make that change to the content within those orders within the system. Different specialties, again, they all have different processes. So one person cannot maintain all these order sets for cardiology, neurology, vascular, ortho. So we typically like to try to call out a subject matter expert, or a SME, as we like to call them. For cardiology specifically, Jessica Livingston is my SME. We also have Tracy Campen that helps out in that area. Sometimes the bill that we do crosses multiple different specialties. So having multiple SMEs for different fields helps, especially with what we did for this order set. We have updated the post-catheterization order set, but some of that bill crossed into some of the other fields. And so we had help from other subject matter experts for that. Entering those tickets. When we enter tickets or want changes to happen, everybody works with these order sets. So we've got providers that enter the order set, and your residents, your NPs, your PAs. You have nurses that act on those orders, as well as your ancillary staff, your PT, your OT, speech, and your nursing assistants. They all act on these orders. Pharmacists, they maintain those medications within those order sets, make sure that the proper dosages are in there. So having each and every one of those people in every one of those areas trying to enter tickets to get things changed gets a little hectic at times. So that's why, again, we like to try to call out one person to send all that information to, and they can filter that out and figure out what does actually need to be changed, what is just maybe some education that needs to be done outside the order set. Number 2, ensuring that our order set enhancements align with current policies and protocols. So once we get all this information from all these different areas, making sure we sort through that information and determine what is best practice. Determine what the current policy at your site is and what the protocols are for the individual procedures that are being done or the post-operative phase. For this one specifically was post-cath. Reconciling our policies and protocols. Maybe we're out of date on our protocols. reconciling them with outside organizations if needed, and updating our policies, and then from then updating our order sets to match our policies again. And then determining what items that are brought forward need to truly be called out in an order set or the education. For example, one thing I bring, do I need to put an order in the order set that tells you to wash your hands every time you go in to take care of a patient? I really hope I would not need to do that. Everybody should know to do that. But do I need an order in that order set to tell you to check that ACT prior to pulling a sheet? I would definitely say that that would be a definite yes. I stumble on my words here. Number 3, establish a process for regular reviews of your order sets related to your policies and/or practice changes. So setting up at your facility a review process within your specialty. How often do updates come out for your field? Is it quite frequently? So maybe we need to look at those order sets twice a year, or is it not quite as often and you look at it yearly or maybe even every other year? So setting a guideline of how often to review those order sets to make sure everything in them is valid and that the orders are actually being used. New faculty brings in new ideas. So they come from another facility where they were doing it this way, and they've noticed improved outcomes at that facility. Maybe we want to bring that into our facility. So practice changes all the time. Let's get those updates made to our order set so then we can utilize that and have improved patient outcomes. Getting to know your SME. So getting to know your Jessica Livingston of your field. Because they are the ones that will be able to know how to get in contact with me or whoever can update your order sets. And also getting to know how to reach out to somebody like me in your facility to be able to get process changes happening. Other thing, when you made these changes, we are able to run reports, and I believe most managers and specialists in each field know how to run reports on these orders, make sure they're being utilized, making sure those orders that we did put in the order set are being followed through. So we put a bed rest order in there. Did the nurse actually keep the patient on bed rest, or did they let them get out of bed right away? Things like that. As I spoke to this order set that we made updates to, it had been since 2013 since we made these updates, and it was 2018, and I think we finally got the updates made to it in 2019. We had utilized the orders and the order groups inside that order set for about a year, a little over a year, maybe 2 years, and noticed that there were still things getting missed, still opportunities that we could enhance. So I had stepped away from my role and had a peer jump in and help while I stepped back into the hospital unit. And we made more updates to that access site panel and those order groups to better help our patients. So with that, I'm going to kind of show you just a couple screenshots of what we actually did with the order set. And then after that, questions if you have any. So this was the previous old build that had been basically since we went live with our charting system at Nebraska Medicine. We had 3 different panels, a radial, a femoral, and a brachial access panel. As you can see, the radial and femoral panels had 3 orders in them each. Nothing was pre-checked, so the providers were going to have to go in and place all those orders, and really not a lot of instruction or anything there for nursing to follow. Very basic. After our update, it gets quite robust. We want to make sure that everything was called out in this order set for nursing to do. So, sorry, my screenshots, I kind of tried to make sure I didn't have 7 pages of screenshots and kind of compiled them into just 1 or 2 here. Up in the top left, this is what the new panel looked like. So you notice that you have a radial access, a femoral access, brachial and internal jugular access. And on very rare occasions, but it does happen, we added another panel for pedal arterial access. For the case that I talked about, it was a femoral access, arterial. They came back with a sheet, so I was able to select that. And it was post-intervention, and we were doing ACT checks. So it narrows it down to very specific as to what needs to be done with that specific type of procedure or that patient. Down in the bottom right, you'll see once I selected ACTs, what needed to be done with that what needed to be done with that sheath and or those ACT checks. So checking that ACT, notifying your provider that the ACTs were done, and what goal were we trying to get to before we pull that sheath out, as well as putting a dressing in place. Next page, again, still a lot more orders, and everything's already pre-checked for the provider, so they don't have to go through and check everything. Up in the top left, we have some nursing interventions. So before the sheet gets pulled, what to monitor, your CMS checks, as well as keeping the patient on bed rest, as well as that once that patient is off, that sheet is out, how long do they need to be on bed rest for, and checking again those CMS checks after the sheet is pulled. In the bottom right corner, we have more interventions. So keeping that leg straight after that sheath is out, or actually while that sheath is in place. Not elevating that head of bed for at least an hour after that sheath has been pulled. What to monitor for when that sheath comes out. So pulses, bleeding, things like that. As well as how long to hold pressure for, what to educate the patient on for bed rest, as well as lifting restrictions and limb restrictions. So we put a lot of stuff in here, very specific to help those nurses and those people at the bedside taking care of that patient on what to do. Yeah, we did a lot of work with this. And again, we came back 2 years later and did even more work with it to make sure it matched our policies, and we caught everything. That ends my presentation. So if you have questions, I will field them at this time. Yes.
Do you get triggered every year or every 2 years to review them, or how do you, what's the process for review?
We don't. And in our system, we have hundreds of order sets. So trying to go through and maintain those for just our smaller group of order set builders is hectic at times. We do run reports, and we're able to see when the order set was last updated. But it definitely does help having those subject matter experts in the fields, or what we call order set owners, that can review those order sets every so often, and then reach out to us, say, hey, we haven't made updates to this in a while, and these orders are outdated. So, any other questions? All right. Again, thank you for having me.
All right, everybody, we're going to get started with our next speaker. Sorry, Marty, you don't get dessert. All right, next up is Marty Max. Marty has been immersed in pharmaceuticals since at least 2004. She obtained her doctorate of pharmacy in 2012 and has been heavily involved in cardiology since then. About a year ago, we were lucky enough to get her stationed in the cath lab, and she has had such a profound impact on staff and patient safety. I've been blessed to work with Marty and get to know her as a friend. So thank you so much for being here, and please welcome Marty to the podium.
All right, thank you, and thank you, Jessica. So I'm Marnie. I'm one of the pharmacists that is in the cath lab at Nebraska Medicine, and I'm here to talk about our presence in this unique area. So I have no disclosures to report. Our objectives for tonight are to describe pharmacy services in the cardiac cath lab, to describe the outcome measures that are being reviewed, and to discuss process improvement initiatives that have been implemented. So a pharmacist in a cath lab is not really a thing most places. And so when we were talking about expanding our services to this area, we talked about what our goals would be. And so we came up with this mission statement that basically is just talking about supporting all members of the cath lab team and elevating medication therapy management, using evidence-based protocols, patient-centered workflows, and process improvement initiatives to make it easy to make the optimal choice regarding pharmaceutical care for our joint patients. So basically just a fancy way to say that we want to support the whole cath lab team. We want to make improve processes so it's easy to make the optimal choice, and then do whatever we can to help elevate pharmacotherapy. So this is the question I get asked most often when people ask what I do, and I say, oh, I'm a pharmacist, I work in the cath lab, and they are very confused. Even other pharmacists, a lot of the times, are very confused with, what do you, I don't get it, what do you actually do? And so I've broken it up into some of our day-to-day activities, and then some of our more longitudinal activities. So this slide highlights some of our day-to-day activities. And the first two sections, order verification and admission and discharge medication reconciliation, are probably our two biggest or areas that we spend the most time. And so, as I'm sure most of you are aware, whenever a provider or a nurse or respiratory therapist, anyone puts in an order before a medication order, before it could become active, it comes to the pharmacist, and then we review it for appropriateness. So looking at it, if it's clinically appropriate, if there's optimizations to therapy that we should make, just looking if the dose is appropriate, or any interactions, looking at it from that whole perspective. And then for our MedRec, this was a big expansion with having a pharmacist in the cath lab. Prior to having presence down there, we didn't have the staff to be able to provide these services to the patients in the cath lab. And so now that we have a dedicated pharmacist and actually a dedicated technician to do the admission MedRec, this has helped expand to now we can provide these services to all of the patients. Whereas previously it was just the overnight stay patients, and now we can offer it to all of the same day discharge patients as well. So this went from looking at about 3 to 5 patients a day to about 20 patients a day. And so with this, similar to order verification, we're looking at these patients clinically. And so when they discharge, we're kind of marrying like what procedure they had done and then any therapy optimizations that should be made on discharge. So an easy example is a left heart cath with a drug-eluting stent placed. So there's very specific medication recommendations on discharge for those patients with drug-eluting stents, high-intensity statin therapy, and potentially ACE inhibitors or beta blockers, depending on the patient scenario. So those are things we're looking at discharge, making sure that the patients are optimized on those therapies prior to leaving. We're also available for emergency response. So if there's a code or an RRT or an intubation in the cath lab, then we will respond to those. We provide education to patients. So the main education we provide is the protect your stent education. And this was a new education that was implemented when we went to the cath lab. And now this has actually become a standard education house-wide. So anyone that gets a stent placed at Nebraska Medicine will get this education by a pharmacist before they leave. We also do education to any new anticoagulants that are started, and then kind of a random one, but Sugamadex, that's a reversal agent for paralytic meds. So some of our patients that get that during their procedures, there's some important considerations. So we always talk to patients about that. And then consult review, we'll get consulted to manage different anticoagulants, so mainly heparin, Bival, or potentially warfarin. for patients that might be admitted. And then new sotalol or Tecousin initiation patients will be consulted to help manage that. And then finally, just being available as a clinical resource. So I sit at the nurse's station in the middle of the cath lab, which is my preference. I'm kind of in the middle of things, so I'm available for any medication questions or issues that I can hopefully help solve. And then from a longitudinal perspective, I've broken up into 3 main sections. So we've been involved in some process improvement initiatives, research, and then staff education. So focusing on process improvement first. When we think about how to improve or what to improve, we look at what is the one thing. So what is the one thing that if we impact, then everything else downstream will be better or easier. And so, so I have some examples of some symptoms of things that have come up, and then the one thing that we worked on to help improve the processes down the line. So couple examples. The first one, the symptom being a variability of heparin utilization in PCI. And so our solution here, which actually Jessica and Nicole and Dr. Malik all worked on this project with me, was to create a heparin dosing nomogram to help standardize usage. And this is something we're actually studying now, so I'll talk a little bit more about that in the research section. The second symptom is DAPT omission on new stent placement or patients. So this isn't something that happens very frequently, but it is a significant omission. So we want it to happen never. So with that happening once in a while, we worked with IT to build a flag on the pharmacist discharge workflow that looks for any patients that get a new stent. If they do not have a P2Y12 inhibitor on their discharge, then we get a flag and we have to address it and communicate with the provider and hopefully get something prescribed. And then finally, overutilization of vancomycin for surgical prophylaxis. So this is kind of, this isn't just an issue in the cath lab or just in Nebraska medicine. This is an issue across the US. So to try to help decrease prescribing of vancomycin, usually this happens when patients have a penicillin allergy. And a lot of these penicillin allergies are more intolerances. Also, there's new evidence with, not really new evidence, but more well-known that there's no cross-reactivity with certain cephalosporins. So with a lot of this newer information and newer push to try to optimize these antibiotics, actually are just finalizing this pharmacy to manage perioperative antibiotic protocol, where we can help review these allergies and determine if they're appropriate to switch or not switch to vancomycin. So this will be something that we're implementing going forward. So I'm not going to talk about all of these, but these are some of the other process improvement initiatives that we've implemented over the last 12 months. Well, some of them I've already talked about. A couple of the other things that we've done is create this Cangalore bridging protocol. This was something that there really wasn't guidance for in Nebraska medicine for the bridging indication specifically. And so we helped create that guidance document and a protocol that we could follow at the Med Center. Recently, we created a P2Y12 inhibitor guidance document and a decision tree to help guide optimal dosing of those medications post-stent placement. One of the ongoing things that I've tried to work on is to optimize inventory to limit the amount of compounding that staff has to do. That's at a time where it could be a high risk or a high stress situation or a time sensitive situation. I want to take that burden off of staff to then have to also compound, and then that risk of potentially an error. So trying to optimize pre-mix products so they're not having to compound in the lab as much as possible. Prasugrel, which is now one of our preferred antiplatelet agents, was not previously available in the emergency department. And as this is our first medical contact for most of our STEMI patients, it was really important that that was available. So that has since been added to the ED inventory Omnicells and added to the STEMI box that the emergency department pharmacists take to all STEMI activations. So moving on to research. the couple of processes that we've implemented. So the heparin nomogram that I talked about, we are also researching this to see, this nomogram is not something that is what is widely utilized anywhere. This is something unique to Nebraska medicine. So we want to first evaluate or validate that it's appropriate. So we're looking at that this year. We're looking at making sure that what we're doing is at least as good as what we were doing before. Hopefully we'll find some improvement. And then we recently completed, one of the residents recently completed an MUE, which is a medication use evaluation. And this was specific to antiplatelet utilization in ACS patients. And with this, we found that we were overutilizing clopidogrel as opposed to some of the more potent antiplatelet agents where have stronger indications in these ACS populations. So from that finding, we've implemented a couple processes to try to help select these preferential agents. And then some future ideas for research that we haven't started anything with, but just some ideas are NSAID prescribing in patients that have ACS or present with an ACS or CVA event, as NSAIDs increase the risk of cardiothrombotic effects. So we want to make sure that these patients, those are being addressed prior to their discharge. And then looking at, again, impact on our P2Y12 inhibitor process implementations that we made. And then if the pharmacist to manage perioperative antibiotic protocol is implemented, again, making sure that what we've implemented actually has some impact. And then since this is a unique practice site, a pharmacist in the cath lab is not something that's common amongst other hospitals or institutions. We are looking at anything that services we've expanded or processes that we've implemented and just reviewing those to see what impact we've had. So any guideline directed medical therapy interventions that we've had, the number of changes or interventions on discharge, protector stent educations that have been provided, the number of times that DAPT core measure has flagged, and then hopefully some intervention on that on discharge, so patients are being discharged on the appropriate thing. And then utilization of our outpatient pharmacy, as that was not available before having a pharmacist down there. And then finally, education. And for this, I wanted to focus on staff education, as I already kind of talked about the patient education. So a lot of the staff education has been involved with the education around the process initiatives that we've implemented. So the heparin nomogram, the Kangaroo protocol. We also recently did some education about heparin and Impella as we were updating that order set. Again, the antiplatelet education in ECS and stable ischemic heart disease patients. Provided education to all of the cardiac fellows on EPIC tips and tricks, as transition to care often can be a confusing workflow. Excuse me, and then high-risk medication workflows as well. And acetylcholine for intracoronary administration, all the protector stent education with everyone, and then anticoagulation checklist for cardioversion. So this was another just checklist we implemented with the nursing staff as a double check, basically to make sure these patients are appropriately anticoagulated prior to their cardioversions. And so lots of information, but I wanted to relate it to individual groups with how can a pharmacist actually help me. And hopefully I have some of my cath lab staff here, so hopefully they know how I can help them. But from a nursing standpoint, how we can be helpful is to help clarify medication issues and help be the go-between if there's questions that we can ask providers and clarify. Expediting order and discharge reviews. So if a patient's in pain or nauseous, then we can review those orders quickly. And if the patient has a ride coming on the way, then we can expedite their discharge review. Patient discharge on education. So we have our standard educations, but we're also available. So if there's unique patient situations or questions that they have, we can always talk to them. Resolution of dispensing issues. So missing meds, on-cell issues, we're available to help with that. And then just as a clinical resource. So any questions or issues that come up, we are there. For providers, we're looking at providing recommendations for guideline-directed medical therapy, optimizing therapy however we can. So making recommendations to them. We hope to adjust orders to hopefully prevent future clarifications required from them. Resolution of discharge prescribing errors. So this is more logistical issues, and this happens a lot, or something that we try to triage quite a bit, where make just simple things like making sure that the patient's prescriptions are routed to the correct pharmacy. Other common things that come up are like prescriptions will be sent to their patients mail order pharmacy. Well, they're not going to get that for like a week. So working with our outpatient pharmacy to fill a week's supply to bridge them until they get their mail order pharmacy. So some of those prescribing issues on discharge, just to help set the patient up for success. And then again, clinical resource, and then I also help with some committee work, including the morbidity and mortality committee with Jessica. And then other disciplines, like I said, we're available for emergency response, education to staff regarding medication topics, and then just availability of a clinical resource for all. So future directions, we have lots of ideas. These are all ideas, nothing is in process, but one of the things that I think would be exciting would be to have an optimized clinic similar to our heart failure. One of our heart failure pharmacists is here, and they already have an established optimized clinic, which is just that, to optimize medication therapy on these disease states where there's lots of evidence about that management. So I think there would be a place for that for our coronary artery disease patients, and would help with transitions of care potentially as well. I've historically implemented, at a previous institution, I implemented a pharmacy to dose insulin protocol, and that's something I've always been passionate about, as diabetes and cardiovascular disease are so closely related. So then just trying to identify some of those patients earlier with A1C testing on more patients than we're currently doing in the cath lab, to help identify potentially pre-diabetes or diagnose diabetes earlier and help intervene on those patients. And then to close, I just wanted to refocus on core values, mainly the collaboration section. So I think I cannot understate how grateful I am for the collaboration from the cath lab team. None of any success that pharmacy has been able to have would not have happened if the team wouldn't have accepted us, and have adopted pharmacy services, and also co-owned so many of these initiatives and agreed to partner with us to make them successful. So I definitely want to shout out my cath lab team, who some of them are here, and I'm just so grateful that they've been willing to adopt us and make it a success. So with that, any questions?
I just want to say thank you, because you've been a wonderful addition to our team.
Oh, well, I feel the same.
I agree.
This is why I love them. Yeah. All right. Well, thank you guys all for coming. Jessica, do you have anything else to say, or should I just close it on out?
I'll just.
Okay.
Thank you, Marty.
I just want to thank everyone again for coming, and again, our industry partners for coming to our event and participating. Definitely, this was a great turnout, and thank you so much to our speakers for taking time out of their busy schedules to come and present on these great topics. So with that, thank you to Jessica, our fearless leader of the CV team, and we hope to see you again next time. Oh, and one last thing, we do have our fall meeting for Nebraska ACC, October 19th. So we hope that you guys will all attend.
Where is it at?
Oh, it'll be at the Marriott Regency in Omaha. We'll be sending, the save the date is already on the website for Nebraska ACC, but we'll also be sending additional information.